mode.
Hi, everyone. Welcome to today's webinar. This is Erin Neinhauser with the Pennsylvania Health Access Network. We are really excited to be joined by Kristen Dama from Community Legal Services for today's training on threats to Medicaid. We're going to get started in about a minute, give folks another minute to sign in and get settled in. A few housekeeping notes while we're waiting. First, this training is closed to the press. So if you are a member of the media, we're happy to talk to you, but this is closed to the press today. Also, you can ask questions throughout the webinar by either raising your hand or typing your question in the GoToWebinar control panel. As we're going through, probably better to type them. We'll have a presentation from Kristen, and then we'll have about half an hour for open Q&A where if you want to ask a question, just raise your hand and I'll unmute your line so that you're able to do that. Everyone who registered will get a copy of the slides from today, so you don't have to worry about taking notes. There's also a screenshot feature, though, with GoToWebinar, so you can screenshot a particular slide if you want to do that, but everyone will get a copy. We're also recording today's webinar, and it'll be uploaded to YouTube, so you'll be able to share that with any colleagues. Let me see if I have any other housekeeping type announcements. If you have any technical issues, you can send me a message through the GoToWebinar control panel in the chat feature. And let's see here. I think those are all my initial announcements. We'll talk more after Kristen's presentation about ways to get involved, next steps, and the timeline. But for now, I want to say thank you so much to Kristen Dama with Community Legal Services and turn it over to her.
Hi, everybody. Thank you so much for having me today and for being on the webinar. This is one of my favorite things to do. I am a supervising attorney at Community Legal Services. I work on Medicaid law and policy here, representing individual clients and also working with PHAN to provide technical assistance and help on how the Pennsylvania Medicaid program works. I do these webinars a few times a year. This is one that I did for those of you who are on, I think it was in January I did one. The first part is going to be a repeat of what we talked about in January. For those of you who are on that one, we're going to run through how the Medicaid program works, because I think it's really important to understand how the Medicaid program functions, both at the federal level and at the state level. But then the second half is going to be totally new because we're in a totally different place. And so we're going to talk about how the affordable or American, I get all my A's and C's and A's confused, but the American Health Care Act would change and hurt Medicaid. Also some state threats to Medicaid that are coming down the pike. And then, as I said, as Erin just said, she's going to talk a little bit about how you can take action. So let's dive in right now and just talk a little bit about how Medicaid works. And when we're talking about Medicaid, we're actually talking about two programs that exist side by side. And to people who walk into assistance offices in Philadelphia, the county assistance offices, everything should look seamless to them, right? They're applying just for one program. But behind the scenes, there's sort of two distinct tracks of Medicaid that exist. And they exist for purposes of both funding and also for purposes of for eligibility rules. And so that's what we're going to kind of run through quickly. Traditional Medicaid is the Medicaid that existed prior to the Affordable Care Act. It's Medicaid that was available for people who were both low income and also worked what's called categorically eligible, that fit into certain buckets of eligibility that Congress had decided were more worthy than the general population to get Medicaid. And that includes seniors, people over 65, individuals with long-term disabilities, so disabilities lasting a year or longer, so people who are getting Medicare and Social Security disability benefits, SSI benefits, or maybe who have shown that their disabilities are significant enough that they're ongoing and rise to a certain level. Kids in Pennsylvania, kids are under 21, and pregnant women, and also very, very low income parents, so parents who qualified for the TANF cash assistance program. Every state in Pennsylvania or in the country has a traditional Medicaid program, although exactly who it covers varies from state to state, as do benefits and eligibility rules. And, we talk about traditional Medicaid as it's one program. That's kind of what I talked about at the beginning. It's one track. But actually, behind the scenes, Pennsylvania has like 30 or so different programs that all work together in a computer algorithm to figure out if people fit into one of these different buckets. And that program still exists, even with Medicaid expansion and the Affordable Care Act, which we're going to talk about a little bit. And the reason it still exists is because of funding. The funding is very different than it is for the Affordable Care Act. So currently, traditional Medicaid is an entitlement. You have to fit into one of these buckets, which they said in Pennsylvania is like 30 plus buckets of coverage. And the federal government reimburses states for 50 to 75% of their costs. And it depends, there's a very complicated formula that determines how wealthy the state is and how much reimbursement they get for every dollar they spend. And so Pennsylvania gets reimbursed for about 52 cents on the dollar. And depending on where Pennsylvania's economy is, sometimes that's gone up to 55 cents on the dollar. Sometimes it's gone lower than this 51.78%. But it's sort of in that general range. States that have stronger economies, like New York and New Jersey, get the minimum reimbursement rate, which is 50%. That's as low as it goes. And states that have much less robust economies and much lower income per capita populations get much more. Like Mississippi gets I think the most of any state in the country. They get almost the full 75%, which is the most that you can get. That reflects that Mississippi is a lower income state. So the other track that I just mentioned briefly a second ago is expanded Medicaid under the Affordable Care Act. So what happened with the Affordable Care Act, for a lot of very complicated political reasons, is that Congress decided that they would fill in the gaps that were created among those buckets. So you had this, these groups of people that could get coverage under traditional Medicaid for the last several decades. And then you had everybody else. And when we say everybody else, we're talking about adults who don't have long-term disabilities, who are ages 21 to 64, and who aren't very, very low-income parents or pregnant. That's who we're talking about. So single people, single 20-somethings, parents who are maybe working a little bit, people who are approaching retirement age but haven't turned 65. Those are the people that were not able to get coverage. And what Congress did was it expanded Medicaid for anybody up to 138% of the federal poverty guideline using complicated tax rules. And those people would qualify for Medicaid expansion. That was initially, as part of the Affordable Care Act, mandatory. The U.S. Supreme Court made that optional. 31 states, and actually I didn't check on this since January, but I still think it's 31 states plus Washington, D.C. have expanded Medicaid so far. Pennsylvania is one of them. And the reason that Congress didn't just take old Medicaid, traditional Medicaid, and expanded Medicaid and mush them all into one streamlined program is because the funding for Medicaid expansion is different as an incentive to get states to want to cover these newly eligible populations. So the thinking was, we have traditional Medicaid, states are used to paying their 50 to 25% of the cost, but for these new people, it's just too much for state budgets, because if you'll recall, this was passed, the ACA was passed, as we were coming out of recession. States just didn't have room in their budget to absorb a new population and pay 50% of the cost, or even 25% of the cost. And so Congress made really good incentives in the ACA for states to cover the Medicaid expansion population. For the first few years, they got 100% federal funding instead of 50 or 75. For 2017, we're getting, all states, including Pennsylvania, which has expanded Medicaid, gets 95% of its costs reimbursed, and reimbursement happens for both programs on a quarterly basis. So the state reports, this is how much we spent last quarter. We get 52% of our costs reimbursed. We get a check from Congress, not from Congress, from the Treasury, for our 52% of our cost of the traditional Medicaid program and 95% of the cost for our Medicaid expansion program. It's going to go down a little bit next year and the year after. And then the way the ACA is written, it's 90% federal funding going forward starting in 2020. As we said, we expanded Medicaid in 2015. We expanded a year late, so we lost a year of that 100% funding, but we had 2 years of federal funding of 100% funding, and now we're getting 95% funding. And since we've expanded Medicaid, we have added a lot of people to the rolls. The traditional Medicaid program usually is about 2.2 million people. The majority is our kids. So 55% of the traditional Medicaid program are kids. And it's really important to note that Medicaid is a much larger program than CHIP. So people often think of coverage for kids in terms of CHIP, which makes sense. It's called the Children's Health Insurance Program. It's perfectly understandable that people would think that most kids in Pennsylvania are covered through CHIP. But in fact, most kids in Pennsylvania are covered by Medicaid, and then slightly higher income children who can't get coverage through their parents' employers or through other means, those slightly higher income children are have CHIP as a stopgap. But Medicaid, Pennsylvania's traditional Medicaid program covers 1.2 million kids. And then since we've expanded Medicaid, we have covered more than 700,000 lower income Pennsylvanians through Medicaid expansion. It's been an enormous success in part because the Wolf administration has really viewed lowering the uninsurance rate and getting people covered as a priority. And we've really seen more and more people come into the healthcare system as a result. Pennsylvania Medicaid isn't cheap, and I think that's really important to note, especially because we are in the Pennsylvania budget season. The last year for which money information was available, we spent $23.4 billion on Medicaid. We got $13 billion back from the federal government. And that was, we didn't have Medicaid expansion in place for our fiscal year, or our full fiscal year of 2014-2015, because our fiscal year runs from July 2014 through June 2015. So we actually get reimbursed more now than we did according to the numbers on this slide. One thing that's really important to note about Pennsylvania's Medicaid program, most of our people on the rolls are kids. Most of our spending covering kids is really cheap because most kids are healthy, right? So even though most of our coverage goes to get kids healthy, get them vaccines, get them early intervention services, well visits, asthma treatment, things for kids, that is relatively cheap. Where most of our spending actually goes is to cover long-term care. Medicare only covers a few days of long-term care services for older adults and for individuals with long-term disabilities. The vast majority of our safety net spending for long-term care comes from the Medicaid program. And Pennsylvania has a fairly gray population relative to the rest of the state, or the rest of the country, And so a huge amount of our Medicaid spending goes to cover individuals with disabilities and seniors, mostly so that they can either age in place in their homes through long-term services and supports, or so that they can go into nursing homes if that's what's appropriate for them. And this is just a quick slide. I won't run through it in great detail, but you can see, Medicaid is a big part of our budget. We have the general fund, and medical assistance and long-term living is 23% of our general fund expenditures. So it is not insignificant, and you can see where most of our funding goes. Little bit of funding goes to families, which includes children, pregnant women, those very low-income TANF parents I was talking about. The newly eligible slice is purple, and the reason it's purple and so little is because we are getting reimbursed by the government. And then the vast majority of our spending goes to individuals with disabilities. I think that's 44%, and then the blue bar is for seniors. And so again, very important as we talk about changes to the Medicaid program by the federal government or by Congress in just a minute. Medicaid programs are state-run, but they have to follow some federal rules. So the federal government has set out some guidelines that if you want to get your reimbursed on this quarterly basis for 50% of your costs, or up to 75% of your costs, or 95% of your costs, you have to do a few things. First of all, Medicaid has to be an entitlement in your state, which means that anyone who qualifies has to be enrolled. So there's certain long-term care programs that are permitted to have waiting lists for complicated legal reasons, but for for just general, run-of-the-mill Medicaid coverage that covers your doctor's visits, your hospitalizations, your prescription drugs, you have to sign up anybody who is eligible. You can't do waiting lists. You can't create artificial lines about who isn't eligible. If you meet the eligibility criteria, you as a state have to enroll someone. The ACA has really streamlined eligibility, and so eligibility decisions have to be made with what's called reasonable promptness, which is 45 days at the federal level. In Pennsylvania, it has to be within 30 days. There are rules about how excessive paperwork. You can't ask people to verify eligibility, criteria that doesn't, that's harassing or that isn't really relevant. You can't just make up new rules for people. You have to follow kind of the baseline eligibility rules. And the ACA has really gone toward using electronic data sources. So using federal databases to confirm people's immigration status, to confirm people's social security numbers, to confirm people's citizenship. Things that can be confirmed through the federal government should be confirmed through the federal government. People shouldn't have to bring in their passports or bring in, their social security cards because, first of all, that's wasteful, and second of all, the federal government has more reliable data that can't be tampered with. It doesn't get blotchy. You can do all that electronically. You have to cover certain benefits, generally doctor's visits and hospitalizations, although with Medicaid expansion, it more tracks the benefits package really tracks what's available through the marketplace, through the Obamacare plans. And enrollees have to have access to community health centers, so federally qualified health centers and lookalikes have to be part of the Medicaid program. You can't say, the Medicaid plans can't say, we don't want to pay health centers, so you can't go there. And this is a big thing that gets a lot of federal, national attention. Texas has really pushed back on this, for example, is that people have to have their choice of family planning providers. And the idea is we have to make it easy for women to get family planning services. You can't just say, oh, you can only go to this list of 6 doctors. Any place that is signs up as a Medicaid provider, including, for example, Planned Parenthood and other women's health clinics, they have to be covered by Medicaid. And really important, and this comes up a lot with lawyers like us, is states can't discriminate. You have to run a program in a way that is accessible for people based on national origin, which includes limited English proficiency. You have to be compliant with the Americans with Disabilities Act. You have to basically protect people and make sure that your program is accessible for a broad range of people and not just the people who have an easy time or relatively easy time getting benefits. With all those rules, states have a fair amount of flexibility. We talked about the minimum benefits, but there are lots of benefits that states can add on, and that includes optometry, dental care, chiropractic visits. States can decide whether they're going to pay doctors directly or whether they're going to have people enroll in managed care plans. Like in Pennsylvania, we have Health Choices, we have UPMC, we have a number of plans. And they can implement limited cost sharing. So most people on Medicaid are very low income. There are safeguards in the Medicaid regulations that really protect people from being denied treatment because they can't pay unaffordable copays or premiums. But states do have the ability to give very nominal copays. Copays that are reasonably affordable for the lowest income Medicaid recipients. People can't be turned away if they're unable to pay. They can keep being reminded, oh, you owe us, $6, you owe us $12, but people can't be denied services if they are below the poverty line. And so that's another protection that exists in law. But states can decide if they want to try to get enrollees to pay premiums when they visit doctors. Pennsylvania has taken a lot of these options. We cover optional benefits. We cover some dental care. We require enrollees to enroll in the Health Choices Managed Care Network, as I said. We have UPMC, we have Health Choices, we have Keystone First, depending on where you are in the state. But most people who are not seniors or individuals with disabilities do have to sign up for a managed care plan instead of just getting what's called access, which is a yellow or green card from the state that you show and the state pays the doctors directly. In the next few months, the state will be moving toward people getting long-term services and supports and other service, and Medicare recipients, moving them into state managed care as well, which is a big change and not super relevant to this, but just this is an option that the state has taken. We also charge nominal copays. People have to pay a few dollars when they go to the doctor. As I said, they're not turned away, but if they do, pay, but if they are asked when they go to their doctors. We have taken other flexibility, and there's other flexibility in the law. One of the big things is that we have a program called PH95, and what that does is it covers children with autism and other serious disabilities so that they can get supportive services. So even for the income rules are much more relaxed for children with autism or serious disabilities, so that because Medicaid covers has this rule that has to cover any services for children, not for everybody, but for children that are medically necessary. And so this allows children with autism and disabilities to get like wraparound services, like speech therapy, physical therapy, other intervention services that maybe they're commercial plans, like plans through their parents' insurance or whatever, might not cover. Beyond these rules, this flexibility, states can also seek what are called waivers. And waivers are basically permission from the federal government, from the Federal Centers for Medicare and Medicaid Services, which is under the Department of Health and Human Services, currently run by Tom Price. They can seek waivers of federal Medicaid rules to test out new ways to provide care. They have to present this very lengthy application that shows that if the rules are relaxed or waived for them, meaning the states, then they are going to innovate in the following ways. Historically, CMS, Centers for Medicare and Medicaid Services, has been very strict about what those waivers can look like, and they have to be related to the purpose of the Medicaid program, which in the beginning of the Medicaid Act says it's to furnish medical assistance. And so states who have wanted to do things like add work requirements or lock people out for not paying premiums, and by lock people out, I mean, say if you don't pay premiums for 3 months, you don't get to get coverage for a year. States who have tried to do that have been told no, and have been said, we can waive certain requirements or relax certain rules for you so you can be innovative, but we are not going to allow you to put up roadblocks that are actually going to keep people from getting medical assistance. And that will become relevant at the end of this presentation. Pennsylvania, this is another area where Pennsylvania has taken advantage of the flexibility that's inherent in the Medicaid program. We currently on the books have 11 federal Medicaid waivers. Most of them allow Pennsylvania to provide long-term services and supports for seniors and individuals with disabilities. I mentioned earlier about waiting lists. This is how we can have waiting lists for some of those services, although I know the state is always working hard to try to reduce waiting lists. It's because we have special permission from the state. We have waivers that allow us to have waiting lists, and in exchange, we help people age in place instead of, only paying for nursing home care. In 2014, some of you may recall, Pennsylvania applied for 14 additional waivers for Healthy Pennsylvania, which was then Governor Corbett's plan to implement lots and lots of changes to Medicaid, both the traditional Medicaid program and also as we implemented Medicaid expansion. It included work requirements, premiums, not having to cover health centers, all kinds of stuff that many of the waiver requests were rejected because they did not furnish medical assistance. They did not meet the purposes of the Medicaid program. A few were approved, but when Governor Wolf took office, he canceled those waivers and said Healthy Pennsylvania is not currently in place. We have a more traditional Medicaid expansion Medicaid program. Our waivers, as I said, most in Pennsylvania, mostly focus on long-term services and supports and helping people stay independent in their homes. So, Erin, do you want to pause for questions now, or do you want to me to just keep going?
We could pause for questions now. I don't see any coming in right now, but if folks have questions on anything that Kristen's covered so far, type them in or raise your hand and I can unmute your line.
Okay, great.
Okay.
All right, hearing none.
Keep going, so thank you.
All right, I'll keep going and we'll do questions at the end. All right, so let's talk about where we are now and how all this landscape that we just talked about might change. So I'm sure that many of you on this call know about the American Health Care Act. This passed on May 4th by a vote of 2017 to 2013. I think it's really important to note, and many of the things I'm going to be talking about are based on this, that the version that was passed in May, I think we heard a lot about the MacArthur Amendment, the Upton Amendment. There are all kinds of amendments to the bill that changed the bill from March to May. What you all need to know is that, unfortunately, or I guess fortunately, to the extent things got worse, very little about Medicaid changed from March to May. And so a lot of the terrible things that we were talking about in March about the American Health Care Act, or the House bill, as I'll refer to it going forward, are still there and are still really, really bad and could get worse in the Senate. And I will talk about that now. So what does it do? The House bill would freeze Medicaid expansion starting in 2020. That doesn't mean that it eliminates Medicaid expansion. And so you've heard a lot of people saying on the news, oh, well, the House bill doesn't get rid of Medicaid expansion at all. It doesn't cut a single person off Medicaid. What it really does is it puts this all on the states. And what it says is that states can cover new Medicaid expansion enrollees beginning, on January 1st, 2020, but you get the regular federal match, not the enhanced federal match. So I just went through all that about the 52% versus the 95%. This is really what this means. This means that for every person who enrolls in Medicaid expansion starting on January 1st, 2020, they would be reimbursed at a 52% rate instead of, the state would be reimbursed at a 52% match instead of a 95% match, or 90% match, I guess, in 2020. And so that is putting a ton of extra money and extra burden on the states to cover people who are getting Medicaid expansion. People who are currently on, as of December 31st, 2019, can be covered by the old match. So if you're on as long as you stay, but you have to stay on for, and you cannot lose benefits for more than a month. And so if you lose benefits for more than a month, what that means is that you can get benefits to get put back on if your state permits you, but the state will only get reimbursed for you at the 52% match or whatever your state match is, not at the 90% match. And so, this hypothetical, let's say I'm on coverage on December 31st, 2019, I lose coverage. I have coverage for until April. So the state gets reimbursed quarterly. So the state gets reimbursed 90% for covering me January 1st to March 31st. Then in April, I'm supposed to do a renewal. I turn in my paperwork, and for whatever reason, maybe I forgot a pay stub, maybe my packet got lost, I lose coverage for the month of April, and I don't get put back on until May. The state is still permitted by the House bill to enroll me, but if the state puts me on in May, and I get coverage in May and June, when it's time to get reimbursed for that quarter, I only get reimbursed for 52% of the cost of covering me in May and June. I don't get reimbursed the state doesn't get reimbursed for the 90% cost of covering me. So covering me for May and June has suddenly become much more expensive. And there's a real disincentive for states to keep the Medicaid expansion folks for people like me who have lost coverage for a month, because all of a sudden they have to come up with 48% of the cost of covering me instead of 10% of the cost of covering me. And that is, for one person, maybe not prohibitive, but for 700,000 people, like in Pennsylvania, that becomes problematic. Just a side note, states can also cover fewer benefits for Medicaid expansion enrollees. They don't have to cover prescriptions. They don't have to cover things that people would get on the marketplace, to the extent the marketplace will still exist. So this is another rollback of protections for Medicaid expansion enrollees. The Congressional Budget Office has not scored the bill of the House bill that passed on May 4th, but they did issue a score in March, and the score was related to the exact same cuts that were in the May bill. So even though the CBA score is old, and you may have seen in the news, oh, they passed this without a CBO score, when they talk about that, they're really talking about a lot of the amendments that were passed. But the Medicaid, the ugly Medicaid stuff in the House bill was not amended between March and May. And so the CBO score is still accurate. We expect that it will be confirmed. And what the CBO said is that most states are probably going to get rid of Medicaid expansion, or either altogether, or they'll just grandfather the people who they're getting the 90% match for and say no new people can come on the rolls. And you think, okay, well, Pennsylvania has 700,000 people. How bad could that really be? Well, the CBO actually says pretty clearly how bad that is. They looked at the churn rate, which is the interruptions in coverage, maybe because of paperwork issues, maybe because people get jobs. If you're lower income, maybe you get a job and then you lose your job and you have to go back on Medicaid. And they really tried to figure out, okay, if we're going to freeze the rolls, most states, say all 31 states plus Washington, D.C., freeze the rolls. They don't get rid of Medicaid expansion, but they say anybody who's on can keep coverage, but nobody new can get coverage. How many people are really going to lose coverage? And it's really bad. It's really, really bad. Less than a third of enrollees will qualify for the enhanced federal match by 2022. So they predict that 2/3 of the people on Medicaid, so 2/3 of our 700,000 people, would lose coverage within 2 years because, of problems at renewal or maybe fluctuating income. For those of us who do Medicaid advocacy, we know people churning on and off the Medicaid rolls is endemic. It's just part of the program. You get coverage, you lose it, you come back on. And that it's so bad that less than 5% of enrollees will qualify for the enhanced federal match by 2024. So the Pennsylvania program, according to the CBO projection, could shrink from 700,000 people to about 30,000 people within 4 years. That's how devastating this would be. And the only way that the states could continue to cover, Pennsylvania could continue to cover this almost 700,000 people that have churned on and off in 4 years, is paying significantly more money to cover them, which given our budget situation seems pretty untenable. So this is, you hear people from Congress going on news shows and talking to the press and saying, oh, we didn't get rid of Medicaid expansion. Medicaid expansion still exists. But this is really backdoor elimination, because within 4 years, you're going to shrink the Medicaid expansion program by 95%, and you're going to create financial barriers that are going to prevent states from keeping the program for anyone else. It's very, very upsetting. That's what's happening for Medicaid expansion. Let's talk a little bit about per capita caps and what's happening at the federal level. As you said, we currently have this entitlement program. Anybody who applies for Medicaid can get it, and the state is reimbursed for all of its costs as long as they, are allowed costs by the Medicaid program. What the House bill would do is it would create per capita caps on traditional Medicaid coverage. So for per capita caps, states use a formula, or the federal government uses a formula, and it tells each state that we're going to give you a fixed payment for each person enrolled in Medicaid. Maybe we give you a little bit more for seniors or individuals with disabilities, but for every person who enrolls, you're going to get a pot of money for that person, and that's your allocation. The problem with this is, first of all, the formula in the House bill gets rid of administrative costs. It is reduced from what states are currently spending. So we're already starting out with lower income or with lower amounts of money than we're currently spending in Pennsylvania for each person that we cover. Even for people like kids who are, as we said earlier, pretty cheap to cover because they're pretty healthy. But the problem is that these caps also don't take into account changes in the Medicaid program over time. And one of the big changes is new therapies. So, for example, when hepatitis C, there's a big panel of hepatitis C drugs that have been developed in the last decade, and they are life-changing. They can, more or less cure people from hepatitis C. Or of hepatitis C, but they are very expensive, and they are partly priced that way because over a person's lifetime, taking the drugs is much cheaper up front than it is to pay for treatment for hepatitis C and the complications over many, many years. That's in part why the drugs are very, very expensive. There's other reasons that is another webinar, but Medicaid has a disproportionately high number of people who have hepatitis C, and so states have covered those drugs partly because they want people to be healthy and they want to provide services for Medicaid, partly because it is treating people with expensive therapies up front is going to save the state and save their health systems money over the long term. And so most states provide treatment for hepatitis C. And in fact, Pennsylvania just brought its standards in line with federal guidance. And so anybody who has hepatitis C has access to these life-saving therapies. With per capita caps, if there's another medical breakthrough for any kind of drug like that particularly as it disproportionately impacts people with Medicaid, there isn't any extra money for that. So states either don't cover the drugs or states absorb a much higher amount of a higher cost, or states put up barriers to getting the drugs. They ration care. They decide we'll cover hepatitis C, but maybe we're not going to cover something else as part of the Medicaid program. You're putting states into situations where they're not able to adapt to changing medical breakthroughs, and that is one of the problems with per capita caps. The big problem with per capita caps, though, it has to do with how they grow over time. So as I said, there's an initial loss, and you can see this little graphic. There's an initial loss where states are going to get less money per person beginning the first year we would do per capita caps. That is an issue at the outset. But over time, it gets much worse. And that is because the per capita caps are growing and are intended to grow at much slower rates than Medicaid inflation grows. So the Medicaid program costs grow a little bit faster than regular health insurance and much faster than regular inflation. And that's for a couple of reasons. One is that people on Medicaid are poorer and sicker, and so their needs, they are just more expensive to treat, and that is why Medicaid is such an important safety net. Another reason is because Medicaid is our long-term care safety net, and long-term care costs are growing and will continue to grow probably faster than the cost of general well-visit care. Health insurance inflation really outstrips regular inflation in general. And so what the House bill does is the House bill only allows the per capita caps for traditional Medicaid to grow according to regular medical inflation and not according to Medicaid growth. And so Medicaid inflation is typically about 4.4% a year. And medical inflation, according to the CBO, is about 3.7% a year. So every year, you have multiplying and compounded losses where the state is getting only a little bit of the money that it needs versus how much its costs are growing. And what that means over time is that states have to figure out how to cut costs. And what they're going to be forced to do, and the CBO report says this very clearly, is that they're going to have to cut benefits, or they're going to have to put some people off the rolls, because they simply cannot absorb, the state budget simply cannot absorb this kind of growing loss over time. And so that is one of the really scary things that we're talking about. And to be very clear, what we're talking about is, states not getting enough money to cover their roles, which have the majority of kids in Pennsylvania. Our roles are 55% kids, but more importantly, again, 72% of our costs are covering seniors and individuals with disabilities. And so we're talking about a cut up front that hurts states, and then we're talking about multiplying, exploding deficits over time. They're going to force states to slash their budget, and the people who are going to be hurt are kids, who make up the majority of the roles, and seniors and individuals with disabilities, who make up the majority of the spending. Those are really the people that we're talking about here, and we're pushing states into a position where we're going to have to make very hard choices about who is worthy of a shrinking pool of dollars and who doesn't deserve a safety net. And that's really, as I said, that's the choice that we are asking states to make with this House bill. A few other things in the House bill that are terrible while I'm running through them. It would lower the Medicaid income limit for kids over 6. The ACA increased, the Affordable Care Act increased the income limit up to 138% of poverty. That is consistent with the Medicaid expansion population. That's a really good thing. CHIP is a great program. I never want to say anything bad about CHIP, but CHIP does not have the same protections for kids that Medicaid does. And that's because, as I mentioned earlier, Medicaid has to cover any services that are medically necessary for kids, and CHIP does not. CHIP does not have the same requirements. And so Medicaid is a really, really important thing for kids who need early intervention services, who need special education services, who need school support, who need behavioral health care. Those are things that Medicaid covers very robustly, and CHIP has a much more limited benefit. And Pennsylvania, in some ways, gets around that because we have the PH95, this special program that we've taken advantage of, the flexibility. But we also, we have a lot of kids who get Medicaid sort of the traditional way and get moved into early intervention services and get the supports they need to grow and thrive. And it is not a good thing to be moving kids out of Medicaid and CHIP. As I said, CHIP is great insurance for a lot of kids, especially healthy kids or kids who just need, basic medical care. But for kids who have serious medical or behavioral needs, Medicaid is much more appropriate benefit. The House bill would also create incentives for states to require enrollees to prove their eligibility every 6 months instead of annually. The ACA requires states to renew eligibility every year. And as we talked about, there's huge numbers of people who lose benefits every year at renewal. Lost paperwork, not understanding that what pay stubs are due. All of that stuff creates what we call churn, which is eligible people losing benefits and going back on the rolls. And by doing that every 6 months, what you're really just doing is harassing people and forcing them to get off coverage. We have to, Pennsylvania, like every other state, has changed reporting. If you become ineligible, you have to report it or it's fraud. So there's already these requirements in place to make sure that ineligible people aren't staying on the rolls. All this is doing is harassing eligible people and making sure that eligible people are going to lose coverage, saving the federal government a few dollars. We would also eliminate 3 months of retroactive coverage for enrollees. So currently when you sign up for Medicaid, one of the things they figure out is, I apply today, it's what's today, May 17th, I can get coverage not just back to May 1st, but I can get coverage for the 3 preceding months. So I can actually get coverage back to February 1st if I have medical bills. And what that does is for people who are in crisis, it gives them a little bit of a cushion to address outstanding bills. Maybe you've been in crisis, maybe you've had critical medical issues that haven't allowed you to apply in those past months. It also shores up our health systems. So you have a lot of people who go into ERs and get admitted to the hospital. Hospitals are paying huge amounts of money for hospital bills. They are able to apply and get retroactive coverage for those folks. And so what you're doing is by eliminating this, is you are putting hospitals on the hook for more uncompensated care, straining their budgets, and you are also creating who haven't been able to apply for Medicaid or maybe have applied but haven't been able to qualify because of paperwork or because of barriers or because they're in crisis. As I mentioned earlier, the CBO has scored the House bill or a version of the House bill with identical provisions. What they found is there's $880 million in cuts over 10 years, just a staggering, almost that should be billion. This does not look very impressive, right? It should be billion, and it's almost $1 trillion in federal spending. So this idea that we're just making the program more efficient or more streamlined, but nobody's going to lose insurance, is pretty laughable when we think about almost $1 trillion in cuts coming out of the program and states being forced to absorb those programs or cut people off benefits. And the CBO has predicted that 9 million Medicaid enrollees would lose coverage in 2020 or as of 2020, and 14 million enrollees would lose coverage by 2026. So more than 50% of the cost from that first CBO score in March, they initially said 24 million people would lose coverage. 14 million were Medicaid recipients, either because of Medicaid expansion or because of states throwing people off the rolls, because of the traditional Medicaid rolls, because of per capita caps. We have a new CBO score that's coming out next week. We're expecting it, it will probably be different than the March one on the commercial side of things, on the, the Obamacare side, the marketplace side of things. We expect it to be substantially similar, if not identical, for Medicaid. So these numbers, I think, are good numbers for us to really appreciate how scary and worrying the House bill is. So as you may have heard, the House bill is now moving over to the Senate, and it's being enacted through federal budget reconciliation. You all probably know this. It's a process through which legislation can pass with simple majorities. So instead of needing 60 votes in the Senate and being subject to a filibuster, we only need 51 votes in the Senate just for the House bill to pass, or for a healthcare reform bill to pass. The Byrd rule, you may have heard about, maybe in a different name. It prevents the Senate from adding provisions to a reconciliation bill that are extraneous or unrelated to spending. So I think you may have heard that, like, the essential health benefits changes to the Obamacare plans and some other things may be stripped from the bill because they are not germane, or they are ruled out of order or extraneous under the Byrd rule. That is not true for Medicaid. Unfortunately, all of these changes with the Medicaid bill can happen through reconciliation. And so I think we should not expect that the procedural rules in the Senate around reconciliation to protect us. This is going to be something that is fought senator by senator, and not, on the floor by the Senate by folks who deal with Senate rules. So there are 13 senators that are meeting Tuesday, Wednesdays, and Thursdays every week to try to hammer out a new version of the bill. Senator Pat Toomey and Senator Rob Portman are taking the lead on Medicaid. So Pennsylvania, we have a voice in Pennsylvania. I will say that Senator Toomey is really emerging as somebody who is really pushing to make the bill worse, and so in many ways for Medicaid. And so he absolutely, like both senators, Senator Casey as well, but Senator Toomey in particular, I think really needs to hear from advocates and partners that that the House bill needs to protect Medicaid, or the Senate bill needs to protect Medicaid, and the House bill is not acceptable. The big source of debate right now between Toomey and Portman and the other folks is about how to deal with per capita cap inflation. So I'm very sad to say that no one is saying, hey, per capita caps are a really terrible idea. We are going to blow up state budgets, and we are going to throw children and seniors and individuals with disabilities off the rolls by giving states less money that they need to provide robust coverage. Nobody on this committee is saying that. And anybody who would be inclined to say that have been kept off the committee. So this committee is a committee of people who are very committed to per capita caps. And the debate right now is centering on inflation. So as I mentioned earlier, the House bill is focused on only growing the program according to medical inflation, which is much different than Medicaid inflation. And so they want to, as I was saying earlier, there's a CBO bill, the CBO score, it says, medical inflation is 3.7% growth, and it really needs to grow at about 4.4%. Senator Toomey actually wants to make that worse. He wants to move away from using any health insurance program or any health insurance inflation as the inflationary measure, and instead have per capita caps grow according to urban inflation. So general inflation, the cost of a price of milk in urban areas on an annual basis, the cost of a tank of gas in an urban area across the nation. That percentage, that sort of general spending in urban areas, that percentage is the percentage that he wants to use, which is actually lower than the House bill percentage of 3.7%. I don't know exactly what it is. I meant to look it up for you all. But it's inflation. It's like how much do our cost of living go up every year? It's maybe 2%, maybe 3%, way less than 4.4%. Very problematic. Senator Portman is actually not, he's trying to make it better, but it's actually not really making it better because he wants to use historic Medicaid inflation, and those numbers are all over the place and not super helpful because, historically, there have been different trends with long-term care, so that they don't take into account what states' costs will be changing. Also, we've added a bunch of kids, we've added a bunch of Medicaid expansion folks who are generally healthier than the population. And so in recent years, our Medicaid inflation has not, for everybody, not seniors and individuals with disabilities, but the healthier folks, has not actually gone up that much. And so it doesn't take into account how these programs might change over time. And so we have this really big problem that the federal government, that Congress really wants to move toward per capita caps, and there's no one who seems to be saying no. And we have this problem that they are actively fighting about inflationary measures that could make the House bill even worse and could make states have to throw people off the rolls even sooner. So this is a really, really big problem and something that our national partners and our Pennsylvania partners are very, very worried about. And Erin will talk in a little bit about how you can raise your voice. They're also debating how to in freezing the enhanced match. There are hardliners in the Senate who want to phase out Medicaid expansion in 2018 instead of 2020. Portman has talked about phasing it out in 2022. Toomey has said, hey, maybe we can figure out an off-ramp. I don't entirely know what that means, but so the year that Medicaid expansion phase out would happen is also in flux, although all of the bad things are still on the table to happen eventually. The other thing that's sort of in the wind right now is that we're hearing that Medicaid block grants might come back. This we talked about some in January for those of you who were on the calls. The Senate may revisit a proposal to convert traditional Medicaid to block grants instead of imposing per capita caps. So block grants are not all that different than per capita caps, and they don't actually even save that much more money. But what they do is they, instead of paying per person, they just give states a lump sum. And so the bad thing about block grants compared to per capita caps is that they're not responsive to enrollment increases. So if you have people, like if the state has, layoffs, a massive business goes out of, even if the economy is strong in the rest of the country, maybe Pennsylvania, God forbid, has a massive industry go out of business, some sort of company, lays off 300 people, 300 people then go on to Medicaid. The state doesn't get paid for those 300 people. It just has to absorb the extra 300 people coming onto the rolls. That's the problem with block grants relative to per capita caps. But as I said, they're still pretty terrible. Per capita cap's still plenty terrible. And the block grants would also grow, not according to the increase in state costs, but according to some sort of inflationary metric that would then be negotiated, whether it would be general inflation, medical inflation, historic Medicaid growth, all those things I was just talking about a little while ago that are complicated, but very much in play in the Senate right now. One more very terrible thing that's coming down the road. The Federal Centers for Medicare and Medicaid Services, as I said earlier, doesn't usually grant state Medicaid waivers unrelated to the purposes of the Medicaid program. But shortly after Seema Verma, the new head of CMS under Secretary Tom Price, was confirmed, she sent a letter to states inviting them to apply for waivers that promote training, employment, and independence. So basically inviting states to ask for work requirements and other things that the Obama administration and their predecessors have historically refused to allow. Maine and Wisconsin, I think maybe Texas now, are currently in the process of applying for waivers to impose work requirements. So they are really like running out of the gate with trying to set up roadblocks to prevent people from getting, get Medicaid. And just to be clear, most of the people who are healthy on Medicaid are looking for work. People who aren't working on Medicaid are generally not working either because they're kids or seniors or individuals with long-term disabilities, or because they're just generally not healthy and not able to work, or they have family members who are not healthy that are keeping them from working. And so this is really intended to more harass people off the rolls than to actually promote employment. In Pennsylvania, Healthy Pennsylvania might be coming back. All those bad waivers I was talking about earlier. State Representative Seth Grove is in the process of introducing legislation that would require the Wolf administration to seek a waiver to impose work requirements, add copays, and make it generally harder to get Medicaid. So that is a state threat that we are also watching as we think about this, as we think about the Senate and where the House bill is going. I'm going to pause there and hand it over to Erin so she can talk about ways that you can get involved. Here's a couple quick ones, but Erin has the much better list. And then I know I ran through a ton of stuff really quickly, and I am really happy to answer questions for as long as we have.
Great. Thank you so much, Kristen. That was really excellent. Just a reminder that folks can ask questions by either raising your hands and I'll unmute your line, or typing them into the control panel. Let me cover a few updates and then we'll move to questions. So we've got some important calls coming up this week. On Thursday, we're having our regularly scheduled field call. We moved it because this week was the primary elections. So Thursday, which is tomorrow at 6:30, we'll have a call where we'll go much more into actions and messaging. We also at 10 o'clock tomorrow are having a call for organizational partners to talk about the latest updates and timeline and how things are moving. So I'll send out the RSVP links to register in an email along with the slides and the Q&A from today's session. So in terms of the timeline, what we're hearing is that in the Senate, they're trying to get this done by the July 4th recess, so it's really important that we act now. Representatives will be home starting next weekend for the Memorial Day recess. So it's not been easy to get a meeting with Senator Toomey, but if you have partners or anyone that you can engage to call and try to meet with staff or with Senator Toomey, that would be really helpful, and especially to put the focus on Medicaid. That's really getting lost in this whole debate. We're hearing that there's concern among moderates and moderate senators about phasing out Medicaid expansion, but there's not quite the understanding of how radical and drastic these changing the structure of Medicaid, taking it from an entitlement to a per capita cap system, or even potentially, as Kristen said, a block grant system, would cause to people that were covered before the Affordable Care Act. So in a way, they're using, quote, Obamacare repeal to do something that certain factions have always wanted to do, which is go after Medicare and Medicaid. So we, in terms of our message, we really need to combat the perception that the harmful pieces of the House bill are dead on arrival in the more moderate Senate. And instead of asking the Senate to oppose the House bill, which kind of gives them an out, we need to be really specific in asking for our three non-negotiables, which is that we oppose any bill that ends Medicaid expansion. We oppose any bill that ends Medicaid as we know it, which is what Kristen described today. And we oppose any bill that would increase the number of uninsured. So through all the channels that we have access to, through op-eds, letters to the editor, personal meetings with representatives and staff, earned media events, whatever we can do, we need to be sounding the alarm, especially about the impact of these Medicaid cuts. So let me see here if there's anything that I forgot. This is just a really crucial time to get engaged. So let me pause for questions. We have a few that have come in. So Kristen, I found a few resources on this. I don't know if you have seen it, but do you know what the projection is for the amount of funding Pennsylvania would lose for Medicaid under the AHCA? How much of our Medicaid funding would we lose?
Yeah, that's a great question. I haven't seen anything that's updated. You know, the CBO certainly didn't come out of that. There's some Urban Institute materials that I haven't looked at in a while because things have changed so much, and I can't. That really ran through this in some detail, so I can direct you there to the Urban Institute, and also tell you that I know our national partners are working on getting state-by-state losses out imminently, and so I haven't kind of dug through the old stuff because I think there is new stuff forthcoming, and I don't know, Erin, if you have anything else you can say about that.
Yeah, I saw just in news articles about $2 billion, and there's a report from the Pennsylvania Budget and Policy Center. So I'll comb through those and compile that and send that out in the recap from today, just so we're clear, because that is a great question. We need to know that. Let's see here. Okay. Yes. Okay. So just to confirm, everyone will get a copy of the slides, the Q&A, and any additional resources that supplement some of the things that we talked about, and links to register for the upcoming field call and the partner call tomorrow. So this is more just general feedback, and we get your thoughts on it, Kristen. So just this being a kind of a bleak outcome, you know, are there any sort of signs of hope or areas that you think? Is there any good news in all of this? Or are there any sort of good pressure points that you see?
Yeah, so I think I would say a couple things. First of all, this is not a done deal. I mean, I think we have seen that, unfortunately, Senator McConnell has appointed a committee that is fairly extreme on Medicaid, to be clear, and that is not really looking to protect Medicaid. But there are lots of voices in the Senate that still do want to protect Medicaid and who are very concerned about the impact of these cuts. And so I think they still have to get to 51. They can, if the Democrats stick together, they can only lose 2 Republicans. And I think it is really, really important, especially as the CBO score comes out. You know, in reconciliation, they can't act without a new CBO score. So whatever they decide, however they want to do per capita caps or phase out Medicaid expansion, you know, there's this new CBO score that's coming out next week, but there's going to have to be subsequent ones. And so I think it's really, really important as we see more and more from nonpartisan sources about how devastating this is, that we really try to lift up how bad this is and make this unpalatable. Because again, even though this committee and what they're drafting is not great, it's really pretty terrible. They still have to get 51 votes to pass it, and it is not clear that they're going to do it. And the more political pressure they get, I think the less likely it is. So I will say that. And then whatever passes the Senate has to go back to the House. And the last bill only passed the House by 4 votes. It is not at all clear that anything is going to pass the second time. And so there is a ton of work left to do. And I think PHAN we are really lucky to live in Pennsylvania and have PHAN be our organizers and be our leaders on this. We just need to do whatever they tell us, because there is a lot of work still ahead of us.
Thank you. So I just want to mention insurepa.org is where folks can go, and you can click on Get Updates to make sure that you don't miss any news, but everyone who registered will get all the links and resources that we talked about today. So we have a question from Destiny. I'm going to unmute your line. Okay, so Destiny, you're unmuted. Go ahead.
Hello?
Hi, go ahead. Destiny.
That was me saying.
Oh,
that
I'm
was me
sorry.
saying hello, Erin.
Okay, I'm sorry. Okay.
Technical difficulties.
Okay. Well, Destiny, chat me if you are having issues, but I'm gonna. Okay. So yes, in terms of next steps, we will send out the resources. Definitely, I would encourage everyone to get on the field call tomorrow with Robin at 6:30, and we'll talk about in-district events. Do whatever you can to reach Senator Toomey, try to reach staff, try to set up a meeting. We really have to raise up the importance of Medicaid, who it covers, and what these cuts would mean in terms of a day in the life of someone who's covered by Medicaid. Per capita caps is a really wonky kind of thing, but at the core of it, is heads, right? They're talking about your head, right? They're talking about all of us and the care that we might need at some point. And so we really have to make that clear and not let Medicaid get lost in all of this. So once again, representatives will be home for the Memorial Day recess. That's an amazing opportunity to pressure them. And we'll be talking more about actions and next steps on tomorrow's call. So let me pause and see if there are any final questions or thoughts. Here's a question. Can they get 250 with Pence?
Wait, sorry. Tell me that again.
So let's, in terms of the Senate, can Mike Pence be the tiebreaker to advance?
Yes. So we have 53. Yes. We have what, 52? Oh my goodness. This is something I should know off the top of my head. We have 52 people. We can lose 2, and then Mike Pence is the tiebreaker. Mm-hmm. Or they have 52 votes.
Okay. And then question here, what's the rationale for including living expenses for people with disabilities and older poor people under health care at all, if there is one?
Living expenses. So you mean like home and community-based services? Just to clarify, long-term services and supports are not living expenses. It's home health care that allow people to age in place. And so in general, historically, the only way that seniors who were not able to live alone or not able to care for themselves, and people with serious disabilities, the only option for them was to go into an institution like a nursing home. And so the idea with long-term services and supports is that if you keep people in less restrictive settings, you allow them to stay in their home. Maybe they have a health aide come and help them bathe, help with meals, not necessarily pay for their meals, unless they qualify for SNAP food stamp benefits, but actually assist them in their home. That is significantly cheaper than having people move into nursing homes. And so thank you for the opportunity to clarify. It's not that we're paying people's rent with Medicaid dollars necessarily. What we're doing is we're keeping people in their home and giving them the supports they might get in a nursing home, but in a much less restrictive and a much cheaper setting.
Thank you for clarifying that. Last question here is, can you talk at all about the impact this would have on parity, mental health parity for treatment?
Yeah, I think that's a good question, and I have to be honest that I haven't looked at the text of the newest bill with all of the changes around the essential health benefits and how parity was a requirement that was made much clearer and much stricter in the Affordable Care Act. And I know, with the MacArthur Amendment, I'm not sure whether changes to parity were passed, and actually people on this call may know better than me. I think that is very likely to be something that is ruled as extraneous if that was, if there was a rescission of parity in the Senate bill. And I don't know, and I'm sorry.
Okay.
But I think that falls under the category of probably extraneous for the general public. I think what we are more worried about is rescission of regulations by HHS around what parity looks like, which is something that could happen and kind of a little bit off the side of this. But I think how Secretary Price might change Medicaid regs is still another threat that is out there on the horizon. And I think there is also a real risk that as states try to figure out how to cut money with per capita caps, especially if they are loosened from strictures, that behavioral health care might actually be something that is on the chopping block. I think that is a very real fear. How that is changed for the general public, I think I haven't followed how the essential health benefits rules are weakened. I haven't read the bill in grammatic detail. All I know is what's been reported, and so I can't talk too much about it there.
Okay. And then we have another question, and then we'll, I think, wrap up questions here. Hang on one second. Okay.
Sorry.
Oh, no, that's okay. So
all my screens popping up at me.
So can you just talk a little bit about the impact on FQHCs and potential clinic closings due to the lack of funding and cuts to Medicaid?
Sure, and I haven't seen this reported. I think what, as I mentioned earlier, one of the big protections in Medicaid is that Medicaid has to cover federally qualified health centers, and there are special payment rules to make sure that Medicaid is supporting federally qualified health centers long term. Oh my goodness, this is a great question. I think there is a lot of focus at the Senate about trying to find additional funding for community health centers, and I am not sure where it's finally going to come out. I think anytime we talk about, there are conversations at the federal level, as there are, both through waivers and also through legislation, about relaxing requirements for Medicaid requirements and giving state flexibility. What we're really talking about is both letting states cover fewer people. We're talking about letting states cover, not cover as many benefits. And there are three things that states have to cover that commercial plans don't. They have to cover the federally qualified health centers. They have to cover Title X clinics. They have to cover, choice of community health provider, which include Planned Parenthood and other women's visits. And they have to cover non-emergency medical transportation. And so when they start talking about that kind of flexibility, that is the kind of thing that states are then going to have the ability to roll back. And one of the things in the federal bill that got reported pretty extensively is that states currently have to treat schools as medical providers to reimburse for special ed services, and they wouldn't under the House bill. And so all of this flexibility, sounds sort of murky and wishy-washy, but what you're really doing is forcing different sets of providers, whether they're federally qualified health centers, whether they're, Title X clinics, whether they're schools, you get them to fight over who gets the money and who doesn't. Hospitals, who are the winners and who are the losers? Nursing homes. And so I think that federally qualified health centers are probably best positioned out of all of these groups because they have champions in the Senate in particular, and a lot of people, like a lot of conservative legislators, really like the idea of health centers, of taking people out of the general health world, not, and in some cases really pushing people to health centers as opposed to, non-health center doctors. So I think that things maybe end up being fine for health centers, but I think given that they are sort of get special treatment, and a lot of special treatment for programs is going away, it's definitely worth being nervous.
Okay, so thank you. So we're gonna wrap up, and if folks think of questions after, email me, Erin@PAHealthAccess.org. Everyone will get a copy of the slides, a link to the recording once it's uploaded, and then some additional resources that clarify and confirm some of the specific issues that we talked about. As you can see here on my screen, there's a letter to the editor's training coming up Monday, May 22nd. I'll include a link to register for that. But we hope to see many of you tomorrow on the partner call at 10 a.m. and then in the evening at 6:30 on the field call with Robin. So thank you so much for everything that you guys are doing. We'll just keep fighting. So thanks for joining. Have a good rest of your day. And thank you, Kristen.
Yeah, you're very welcome. Thanks for having me, everybody. Bye.
Bye.